All right, so I'm up next. I'm going to give a lecture on drowning. Chose this topic for a couple of reasons. One of the biggest things is that this is not something we see a lot at Kings County and downstate, but definitely something we have to be prepared to take care of in the emergency department. It's definitely appropriate for the current season and the summer months that we're going into. And it's a very scary thing. It's majority a pediatric issue. We see this mostly in kids. And where you go to work in the future could be something that you have to deal with. It was working 2 seconds ago. Okay, so what we're going to go through is we're going to go through epidemiology. Epidemiology is a pretty big deal in drowning, so it kind of gives you an idea of what kind of patients we're talking about, where we're talking about, and where you can do some education and prevention. And prevention is going to be a quick slide or two at the end, but this is extremely important. And even as emergency physicians, this is something that we should be thinking about when we're taking care of pediatric patients, talking to parents who have small children, maybe not even have pools or swimming, and then obviously with any parents who are bringing their kids swimming or have pools and things like that. And we'll talk a little bit more about that. And then we'll talk about the pathophysiology and the management of a drowning patient. So this is the statistic worldwide. There's 370,000 drownings across the globe. Actually, I made this lecture a couple of years ago, and it was 500,000. So I guess we're doing something right. This has been decreasing. And a really jarring statistic is that 80 to 90% of drownings are preventable. So again, we'll talk a little bit about prevention techniques at the end, but this is something that is pretty significant, that this amount of these 370,000 drownings could be preventable. In the United States, the CDC says that in 1 to 4-year-olds, it's the leading cause of accidents and deaths, second in 5 to 9-year-olds, and third in 10 to 14-year-olds. This was a study done in pediatrics in 2001, looking in 1995, which is a while ago, so it might be a little different, but I suspect not too different. Looking at 1,420 deaths, 47% of them were in freshwater, 31% in pools, 9% in baths or buckets, so these are at home, 4% in salt water, 8% were unknown. 78% of the infants who are drowning were at home. So again, this is definitely even in an area where we're not by the coast or the shore, and not a lot of people have access to pools. This is a time for prevention and education for our patients. Swimming pools are more likely to be non-fatal. Hopefully that's because somebody's watching. If you have a swimming pool, children are usually going to be maybe taught how to swim. And then in natural water is higher likelihood of fatal. And this is probably because swimming in rivers, lakes, maybe somebody's not watching, there's not someone supervising. And then June through August are the highest rates, which is pretty obvious. So some risk factors. So what do you guys think are risk factors for drowning? I put up some nice pictures that give you clues. So good. So in terms of prevention, so if you have a pool or an area that doesn't have protective fencing, what else? Alcohol, good. Yeah. Intoxication in general. Anything else? So epilepsy. So epilepsy, what's the statistic there? It's 15 to 19 times greater chance of drowning. No change in risk if they're supervised, which is interesting. Anything else? Men, males in general. That's just for risky behavior. And then children, so less than 14-year-olds, you have a higher risk. And then cardiac arrhythmias, so anyone who has a congenital arrhythmia, so like prolonged QT, Brugada. And this is because of a catecholamine effect of going into the water, either a cold response or a diving response. And then there's actually a pretty significant racial and economic disparity. It's shown that low middle income countries rates are much higher. This disparity is more significant in the ages from 1 to 3, and with lower incomes, poor education rates, and in rural areas, drowning is higher risk. This was a study looking at income as a factor, and it showed that lower income had half of the drownings in this study. whereas higher income, over $48,000 per year salary had only 22% of drownings. All right, so let's talk about the pathophysiology. So I'm going to kind of go through what happens when somebody's drowning. So the first part is called the struggle. So this is when the person's airway is above water and where you hope that you can hear the person, you can see that something is wrong. A lot of times it's not that loud. You may not hear someone screaming out because they're panicking, they're scared, they're trying to catch their breath. And a lot of times in some of the times when people are going to drown, it's a loud, crowded area, so it can be not noticed. And this can last only 20 to 30 seconds, so it's not very long. And then the next step is when the airway or the person goes underwater. They have voluntary breath holding. And again, we all kind of think that we can hold our breath for probably a couple of minutes, but usually this only lasts for about a minute or even less, again, because of panic. And you're not thinking, and the person's not thinking that, oh, I need to hold my breath. So usually only less than a minute, they have voluntary breath holding, and then they start aspirating water. The coughing reflex happens, you have laryngospasm, and then you start having hypoxia, hypercarbia, and acidosis. You have decreased arterial oxygen tension, you have more laryngospasm and more aspiration. Until the cerebral hypoxemia kicks in, and then there's coma, loss of consciousness, and apnea. And the final pathway is cardiac arrest from hypoxemia and acidosis. This can actually take from seconds to minutes, so it can happen very, very quickly. In the lungs, the primary pathophysiology is shunting and VQ mismatch. You have some bronchospasm, and there's an idea of surfactant washout because of all of that water going in there is washing out all the surfactant. And then again, cardiac is really due to a respiratory cause from hypoxia, acidosis. You're typically going to have the heart become tachycardic, and then you're going to have that bradycardic arrhythmia from hypoxia, and then you will have PEA and asystole. Very, very uncommon to have any VFib or VTAC. If you do have a drowning victim who has these rhythms, you should think that there was probably an underlying cardiac issue that could have caused the drowning. All right, so we're going to talk a little bit about nomenclature before we get into management because it kind of helps us think about how to manage these patients, and also it's important in terms of how we document what's happening with a drowning victim. There was a lot of different ways to classify this, and it made epidemiology difficult and kind of made studies difficult. So in 2002, the WHO adopted the Utstein style, which is basically just binary. All drowning should be described as either fatal or non-fatal. There were a lot of other terms: near drowning, secondary drowning, wet drowning, dry drowning. So all of these should be eliminated from your documentation and how you talk about drowning. I want to take a quick moment to address dry drowning. Has anyone ever heard of this term or this concept? A couple of years ago, it was in the popular media and talked about a lot. The idea that somebody could drown without having any water exposure. And this is not, I'm not talking about being buried alive or quicksand like the picture is. And it caused a lot of hysteria and a lot of people to be scared and bringing their children in. It's been debunked. There was many decades ago, some pathologists who wrote about it, looking at patients that drowned but didn't have any pulmonary damage. So this may have been sensationalized because of something called secondary drowning, which I will go into a little bit later. A little bit about nomenclature. I think you should describe whether this was a freshwater or saltwater. And then something that is significant is whether this is a cold or a warm drowning. So warm drowning is typically above 68 degrees Fahrenheit or 20 degrees Celsius. Cold has a little bit of variation in terms of how they describe it, but typically under 20 degrees Celsius is going to be a cold drowning. All right, so we're going to get into a little bit now what we do for these patients. So we're going to start pre-hospital. So the patient is a drowning victim or concerned for it, and then the EMS comes. What do you think are some of the considerations for pre-hospital or EMS for a drowning victim? Always, yeah. Always you're going to think about the scene and safety for EMS for sure. What about, so they get to the patient, what are they going to think about in terms of taking care of this patient? Sorry. So C-collar, good. I have a picture of it later, but actually it's very overestimated. Only really 0.5% of drownings have any cervical injury. So, okay, if EMS wants to do that, but something for you to think about if a drowning victim comes in with the C-collar, really delve into the fact that was this traumatic, was this a patient who dived in, hit their head, because usually not that much concomitant C-spine injury. Anything else? Oxygenation, perfect. So as we'll talk about a little bit more, all of drowning is hypoxemia, so you definitely want to give oxygen. Most EMS is going to have a pulse ox, so you're going to check the oxygen level. So a couple of other things. It's been shown that starting CPR in the water has benefit if the patient is in arrest. So most lifeguards or pools will have a rigid board. So if it takes a prolonged time to get the person out, if you can start CPR in the water, that is beneficial. As we kind of talked about, this is less of a circulation issue and more of an airway issue. So you really want to think about this as ABC rather than that ACLS CAB thought process. So even the Europeans actually recommend giving 5 rescue breaths before starting compressions at all, which goes against what we usually think about in ACLS now. C-collar, as David talked about. Hypothermia is a big problem with drowning, so I'm not going to talk too much about hypothermia management, but realize that hypothermia can be concomitantly going on with drowning and hypoxemia and airway issues. And then this is not something I think we do a lot, or EMS does a lot now, but just remember that any endotracheal tube medications should not be given. So usually in our BLS or ACLS protocols, you can give medications through the ET tube, but because there's going to be aspiration and decrease in that VQ mismatch, it's not going to be absorbed. So don't expect that will be working. So quickly, I just want to talk about grading. This is not really that helpful in terms of thinking about drowning victims, but I think helpful because EMS may be thinking about it this way. And if you're in a place where they're communicating with the ED specifically, they may use this. So the grading for drowning really just looks at these 4 things: the responsiveness of the patient, if they're coughing or have some sort of respiratory irritation, do they have rails on exam, and their hemodynamics. So in a patient who has none of these, is fully responsive, normal hemodynamics, no cough, and no rales, that's actually considered a rescue, so not a drowning. So the definition of drowning is pulmonary dysfunction after submersion. Grade 1, you're going to have just a cough, be fully responsive, normal hemodynamics. Grade 2 is some rails with normal hemodynamics. Grade 3 is rails throughout. Grade 4 is rails and hemodynamic abnormalities. 5 is unresponsive, and 6 is cardiac arrest. There is a lot of literature talking about who needs to be transported and who doesn't need to be transported, and that may be more of an issue in other institutions where maybe transport times are significant, maybe you're out in a rural area, but for the most part, they recommend transporting everybody. But I guess if you are in a rescue or grade 1, there's some thought processes that somebody can go home and be watched closely. But I'm going to say, if you're ever in a situation where you're making that decision, transport everybody. And we'll talk in terms of the algorithm. These patients can decompensate. All right, so now the patient's in the emergency department. And basically, what you want to think about is that, like every other patient, is this patient sick or is this patient not sick? So quickly, I will just go over that kind of branch point. So if they're sick, you're going to do what you all do for every patient that comes in cardiac arrest or is hypoxic. You're going to reverse hypoxemia. You're going to intubate this patient. You're going to give them fluids, start them on pressors. There is some evidence that ionotropes can help as well in terms of increasing cardiac function. But probably the best thing is keep it simple and use what you're comfortable with. So using something like Levophed is fine. There's been studies looking at steroids and bicarbonate, and they don't help. In terms of the not sick patient, the biggest diagnostics are, first of all, you want a pulse ox on everybody. A chest x-ray is helpful, and I'll talk about that a little later. And then other tests like blood tests and the usual things that we send, there's not really significant data that you're gonna get from that. But the big thing that we do as emergency physicians and that we have to think about is etiology. So is this just a kid who doesn't know how to swim and got into trouble? Maybe, but think about, is there concomitant trauma? Is there an underlying arrhythmia? Is there a concern for abuse or neglect? These are the things that we have to think about while we're resuscitating the patient and making sure they're okay. All right, so I'm just gonna go through kind of a pathway and how to manage these patients. Every patient comes in, you're gonna think about ABCs, everybody gets a pulse ox, everybody should be on oxygen initially, and then think about C-spine injury, but as I said, it's pretty overly estimated. If they are in apnea arrest, as we talked about, you're gonna do CPR, you're gonna intubate, pressors, ionotropes, diagnostics, probably not gonna be super helpful in this case, and they're all gonna go to the ICU. Things that the ICU team is going to think about, and maybe you can know a little bit about, ERDS is common, so think about vent settings in that setting. They really recommend do not wean these patients off for the first 24 hours to let the surfactant regenerate. And then later complications include pneumonia and cerebral edema, but there's no recommendation for empiric antibiotics, so we don't have to worry about that in the ED. Something that we should think about in ED is ECMO. These are patients who have pulmonary dysfunction, later down the road, maybe cardiac arrest. So if you are an ECMO center or you can transfer to an ECMO center, these are usually very young and healthy people. So this is something you should think about early. If the patient's in distress, hypoxic, borderline mental status, again, oxygen, pulse ox, an ABG may be helpful just to see what the respiratory dynamics are, diagnostics as you see are fit. And all of these patients should be watched for 4 to 8 hours in the ED because I wouldn't recommend just admitting them to the floor because there is a high chance they may decompensate and you may need to intubate them. So being watched in that acute setting before they get whisked to a regular floor, I think would be recommended. There is some studies about non-invasive ventilation. It's shown that it helps. It helps people with work of breathing, hypoxia, but it doesn't really, I don't think the data is there to say that this is going to prevent patients from going to the ICU. It's going to prevent intubation, which makes sense from the pathophysiology. This is more pneumonitis and ARDS, so non-invasive is not going to really stop that pathophysiology. So use it and maybe making the patient comfortable, but don't feel reassured that this patient's not going to decompensate because they're on non-invasive ventilation. So these are the tough patients. They come in with normal vitals, normal GCS, and so these are always the ones you're going to want to watch. They all get a pulse ox, and this is where a chest x-ray can be helpful. If a chest x-ray is completely clear, you should feel reassured, but you're still going to want to watch that patient for 4 to 8 hours. If a chest x-ray shows any signs of pneumonitis or pulmonary edema or infiltrates, this is a patient that has a higher likelihood of decompensating, and you should still watch them, but they're going to be admitted every time. And actually, the literature suggests that you should have social work involved for any patient, whether they get discharged or admitted. There's usually a lot of psychosocial factors to drownings. So this is what I was going to talk about, what I mentioned before, secondary drowning. So this is really the idea of a patient who initially looks normal, has some mild symptoms, is not hypoxic, and then develops secondary drowning. And what this really is just a delayed pneumonitis. And the evidence looking at this in retrospective studies shows that the chest x-ray is actually a really good predictor, and that they recommend all patients have a observation period, and 4 to 8 hours is what's quoted. This was one study that showed some signs of poor prognosis. So less than 3 years old, submersion greater than 5 minutes, a delayed rescue time over 10 minutes, coma or a pH less than 7.1. If you had 3 or more of these factors, you had over a 90% chance of death. So, and that was irrespective of hypothermia. So something to keep in mind, maybe to talk about prognosis, counsel parents and family. Special circumstances, so bucket drowning. This is seen in 8 to 15-month-olds. So children who are exploring their environment, looking at things, so they can actually look in a bucket that has liquid, fall in, but they don't have the strength to get themselves out. So this is something, again, to counsel parents, counsel families when you're seeing them in the ED. Bathtub drowning, you should counsel your parents that you should never leave a child unsupervised in a bath. This was actually a chair that was used to be sold for baths to kind of give reinsurance, but there were a lot of cases of infants knocking over the chair and actually drowning in a small amount of water. So I'm pretty sure these are completely off the market now. Stagnant water, or what's the word? Like swamps or polluted, not polluted, but contaminated water. They actually can have delayed pneumonias up to 4 to 6 months afterwards. It's usually gram negatives, aerobic gram negatives, like the Aeromonas species, but something to think about in terms of the ED if someone had a drowning episode in water like this and they present significant amount of time later, that could be related to the drowning. So extreme less than 10 degrees Celsius drownings. There's actually been a couple of case reports of meaningful recovery, normal recovery for patients that have had prolonged downtimes and come in very, very sick. There's not great evidence for what to look out for, what to know about it, but I think just for us to know that if you are treating a patient who is drowned in extreme cold temperatures, that there is a chance that you may get them back. So you should probably work longer on them and probably work until they are a normal temperature. So prevention. So quickly, we'll go over some prevention. So these are things to think about. Pool fencing. So anyone who has a pool is pretty much code now, but something to maybe ask if someone has a pool and you're seeing them in the ER, do they have fencing? Education and awareness is huge, and this includes a lot of the things I spoke about in terms of even just infants and bathtubs and buckets, but also teaching parents how to perform CPR, teaching children how to swim. Lifeguards obviously very helpful. Flotation devices, there are recommended flotation devices, so talking to parents about looking that up. And then hot tubs are something some people forget about in terms of drowning risk, so they should have covers and they should lock, so a child can't lift it open and jump in the hot tub. I don't know if this is gonna work. All right, I don't think it's gonna work. It was a shameless use of my child learning how to swim, so. Okay, any questions? Good. No, there's no recommendation to repeat the x-ray. You can have the initial x-ray, and that's predictive if they are going to decompensate. But usually, if you're watching them 4 to 8 hours on pulse ox and re-examining them, the recommendation is that they're okay to go after that. Anisha? It's been looked at, not really, no. So they do say to classify it differently, but in terms of the pathophysiology and kind of the longer term, really no change in terms of their outcomes. Not that I saw. It's really just to watch out for the delay of pneumonia. It's like any kind of aspiration or pneumonitis. It's usually not that initial injury. It's something that develops afterwards. So the empiric or prophylactic antibiotics aren't really going to change anything. It was looked at. Steroids hasn't been shown to help. I'm sorry, what was the second thing you said? I mean, you would just treat there's like an inflammatory reaction, like you would like antipyretics or anything. But they looked at a couple studies, and it wasn't shown to help. I think I read about some deep suctioning. I don't think it had any change in the kind of course, but I'm not 100% sure about that. But I don't. I think I read something, but I didn't put it in because it didn't change anything. That's a good question. So I looked at it. I think it's similar to ultrasound. If you do see B lines, that's going to be something I would do an X-ray if you see any abnormalities. I haven't seen any specific studies looking at prognosticating due to ultrasound, but I agree. For me, if I put an ultrasound probe on and I see B lines, for me, that would mean that the patient's staying. So just learning points. This is all due to hypoxemia. You guys know how to treat that. So at the very, very basic levels, that's what you're going to treat. Think about etiology. That's what we do. So don't just, kind of stop at the fact that this is a drowning victim. Think about why this happened. Pulse ox and chest X-ray at the minimum for these patients. I would observe everyone and transport everyone, and then think about prevention after you take care of the medical stuff. All right, that's it. Oh, yeah. I don't think so. I mean, first of all, CCT is kind of a Kings County thing. You don't always going to have a critical area. I think if they have normal vitals and they can be put on a pulse ox and someone you can check on, they can be in a main ER or a non-critical area. I think if they come in and any altered mental status and any oxygen need, I would probably put them in a more critical observation area. All right, thank you guys.